Out there. My name is Dr. Jamie Van Gumpel, a neurosurgeon at the Mayo Clinic. Just wanted to put this out there to talk about why one might consider a surgical therapy for prolactinomas, given how many of these usually are now treated with medicine. So we'll just go over that real quickly here on these slides. So just want you to understand or gain appreciation for when surgery may be considered for prolactinomas and gain further understandings for the effectiveness of surgery with these particular tumors. Prolactinomas are the most common pituitary adenoma. They represent 50% of all pituitary adenomas, and they can present with either high levels of prolactin, which is what they make, causing breast discharge, reduction in sexual interest, and subfertility. They can also cause problems by pushing on the eye nerves. Medical therapy with dopamine agonists, bromocriptine and cabergoline are first-line therapy for these. We'll go over that briefly here. The majority of these are microprolactinomas, which are 63 to 85% of these. The peak incidence occurs in 20 to 50 years, and surgery is common until 1970 when bromocriptine was introduced. In 1990, cabergoline was introduced, and that had better control of prolactin levels with fewer side effects. The side effects in these medications can include hypersexuality, some additional psychiatric side effects can also cause some GI distress and things like that, as well as long-term use can cause valve problems within the heart. So we have a lot of evidence with these particular medications, how they work, and they work well. Prolactinoma surgery, unfortunately, not every patient can tolerate the therapies due to side effects, nor do they want to be on medications lifelong, or the tumor may not completely respond to the medication, either radiographically or symptomatically. And we don't really know what the lifetime effect of bromocriptine and cabergoline are. However, we suspect that it has a low risk of causing long-term problems. In patients such as this, surgery is then considered. And I just want to highlight that what we're doing now for these tumors with more aggressive resections, given the introduction of the endoscope, is not necessarily representative of some of the data we'll go over here. But this is a summary of the literature on those types of things. And this is just slides demonstrating the difference between a microscopic and endoscopic resection. The bottom part is the endoscopic resection, which we certainly can see a lot more and remove a lot more than we were able to decades ago. So what number of patients can withdraw medical therapy effectively if they're completely responsive to medication? Well, it turns out that if you can't see the tumor, you can come off of that medical therapy 2/3 of the time. However, if you can see the tumor, 50% of the time you'll come off the medication at 5 years. And this paper was published by this group in New England Journal of Medicine, a pretty reputable journal, in 2003. So dopamine failure has a variety of different definitions. Here we're using dopamine resistance, failure to achieve normal serum prolactins after receiving a bromocriptine dose of 15 milligrams or a cabergoline dose of 1.5 to 3 milligrams weekly. It should be noted that you can go on higher levels of these and you can still have a complete remission. So cabergoline is approved for up to 4 milligrams per week, and sometimes we can go higher. It should be just noted that that's the case. And dopamine intolerant patients are those who cannot tolerate the side effects of the dopamine therapy. This was briefly our search strategy, in which we found 611 records that were dealing with prolactinomas. Ultimately found 10 records or papers that were able to provide data that we could use for this study here. So in this particular cohort, this included dopamine resistance patients of 46%, intolerant patients of 16%, 2% fell in both categories, and patient preference for surgery was a reason for surgery in 13%. The additional patients, we could not track that down. So what percentage of patients achieve early remission with surgery? There's 8 studies addressing this, and it looks as though approximately 50% of patients achieve early remission. And these bars just simply represent the variances as well as the reported remission rates. So in this Donegan paper, it's 50%, and Fernando Valley's group reported a 77%. But in general, it's almost 50% of patients achieve initial remission without additional medical therapy in the short term. 6 studies looked at recurrence. We saw 16% of patients recur within the follow-up period. The average follow-up period was 27 plus or minus 9 months. And remission at last follow-up. So this is long-term results that we were able to achieve in 588 patients across all studies reported, with follow-up at 49.2 months. 38% of patients remained in remission off of medical therapy, or you may consider cured in this particular group. If the tumor was larger, there was less chance. So any tumor over 1 centimeter, 22% achieved long-term remission with surgery alone. And if it was smaller, 66%. So I think this would paint a picture that if we have a smaller tumor that's visible, certainly a surgical removal has a higher success rate in that particular circumstance, depending on how that tumor looks. So from this analysis, 62% of patients eventually achieve remission with not only surgery but plus medical therapy at last follow-up, which is significant if you consider a substantial proportion of these patients did not have remission just with medications alone. We were unable to determine if patients had reduction in postoperative medications in this group besides using or not using medications. The data wasn't fine enough for us to discover that. So in conclusion, 38% of patients achieved remission at last follow-up without need for further treatment, and 62% achieved remission at last follow-up with multimodal therapy, with 46% requiring dopamine agonist therapy. Again, larger tumors did worse than smaller tumors in this particular group. So therefore, although surgery has not been the initial therapeutic choice for prolactin illness, plays a significant role in medically failed and medical intolerant patients. So what do we learn from looking at this? Surgeons need to be realistic about their assessment for their ability to remove a tumor completely. Not all surgeons are equal. Not all techniques are equal in this particular grouping. And however, the morbidity of the operation needs to be weighed against the morbidity of continued prolactin elevation versus growth. For instance, we do not perform cavernous sinus resections for these tumors unless the growth is threatening their life. So that's a large resection or more of an aggressive tumor that we don't commonly do for this. This is a patient who's 25 years old, female, intolerant of cabergoline and bromocriptine. She was treated for 2 years and prolactin had not completely suppressed. She had severe nausea with treatment and lost 25 pounds. And she was concerned about meds during pregnancy. She's married and currently trying to do so. You can see, I'll go back. You can see that after 2 years of meds, this tumor shrunk in the lateral aspect of the pituitary gland, but you can see it's within the gland and very anterior. So pretty straightforward, easy approach for us. So if you were to go in and radically resect this, which is what we did, and when I mean radically resecting, I don't mean just opening this up, scraping it out and closing it. What we do is we resect the dura over it, resect part of the pituitary gland around it and the cavernous sinus adjacent to it. The cavernous sinus wall, not the whole cavernous sinus, of course. I won't show the video because that in this particular circumstance doesn't allow this to be shown on YouTube. However, what we see is the postoperative prolactin drops immediately intraoperatively because this half-life is pretty quick, and long-term this patient's been in remission without additional surgery for over a year at this point in time. Quickly, we'll cover radiosurgery for this. So this is an option. We did a similar type study in which what we saw is 700 patients treated with a mean margin dose of 24.1 gray, max dose of 54.5. And what we saw was it took almost 54 months for patients to get into remission if they were going to. 33% of patients were able to achieve endocrine remission in this particular study or this particular report, with 9 studies of 678 patients looked at. 60% of patients, 62% of patients were able to achieve endocrine control, so improvement overall plus medications. And systemic symptom control was achieved in 54% of these patients. If we looked at reduction in dopamine therapy, 34% of patients decreased the dose of dopamine agonists or even completely ceased their dopamine agonist therapy after SRS, which is what most patients are looking for. New post-treatment hypopituitarism was 26% in this group, There were no visual complications seen. Um, and what I think is most interesting in this group is commonly we stopped the medications prior to radiosurgery. We did not see effect with that in this particular group. So our conclusions were 33% of patients achieved endocrine remission without need of further therapy within this Gamma Knife cohort. 64% of patients achieved radiographic regression, and 26% of patients had new hypopituitary asthma after, which is important for patients seeking treatment with these. This is a very interesting analysis that was released in 2020, looking at surgery alone versus dopamine agonist studies. And I'll just quickly go to the punchline on this, is that when we looked at surgery as a viable alternative first-line treatment, what we saw was in this reported group higher rates of control, 83% with microadenomas and 60% of patients with macroadenomas. And this was more of a selective group than what we reported in our literature summary. What we looked at with long-term remission with off medications was quite lower. This group looked at was 36% with microadenomas and 28% with macroadenomas. However, medication control with continued medication was still quite high, 91% with micros and 77% with macros. So what their conclusion was, in the majority of prolactinoma patients, disease remission can be achieved through surgery with low risk of long-term complications. And it's important, I think, to consider this as a therapy up front for if you have a prolactin-secreting tumor. So in general, what I think the point of this talk is to just say that I think it's important to meet with a surgeon prior to considering the medical therapy for this, although likely you will go on the medical therapy route. Medical therapy can always, you can always come off that and attempt surgery. The surgeon give you a good sense as to whether or not your lesion might be curable. But I think it's reasonable to consider and select patients this particular approach. I hope this was very helpful for you. Have a great day.